We all have a general timeline in our heads for when puberty kicks in, that huge transition. But what happens when that starting gunfire is way, way too early?
hmm
That's the really fascinating area we're exploring today, precocious puberty. We've got some pretty detailed revision notes here to guide us.
Exactly. We're talking about sexual development starting much, much earlier than the usual ballpark. So before age 8 for girls and before 9 for boys.
Right. So our goal today, our mission really, is to dig into these notes and pull out the essential knowledge you need about precocious puberty.
Yeah, the key stuff.
Consider this your fast track to getting a solid handle on the condition. Okay, let's dive straight in. What exactly is the definition of precocious puberty?
Well, simply put, it's the early appearance of those physical signs of sexual maturation. And like you said, those age cutoffs are absolutely critical before 8 in girls, before 9 in boys. And what's really important is that we can broadly split it into two main types.
Two types. Okay, tell me more.
So first, there's gonadotrophin-dependent precocious puberty. It's often called central.
Central, okay.
Think of this as the body's main puberty control center, in the brain. It gets switched on prematurely. The hypothalamic-pituitary-gonadal axis, that key communication link between the brain and the ovaries or tests, it just activates too early.
Right.
And this leads to higher levels of two hormones, FSH and LH. Now, often we actually don't know the exact trigger.
That's the idiopathic type.
Exactly, idiopathic. But it can also be linked to issues within the central nervous system itself. Things like tumors or injuries or certain conditions someone's born with.
Okay, so that's the central pathway triggered by the brain. What's the other kind?
The second type is gonadotrophin-independent precocious puberty, or peripheral.
Peripheral, got it.
Yeah. So here the body produces excess sex hormones, but without that early signal coming from the brain. So in this case, FSH and LH levels are actually low. It's like the ovaries or tests, or sometimes even the adrenal glands, are kind of going rogue and making hormones on their own.
Right, acting independently.
Precisely. And this can be caused by things like congenital adrenal hyperplasia, certain kinds of tumors, and genetic syndromes like McCune-Albright syndrome.
So just to check I'm getting this, central is like an early command from HQ, the brain.
High FSH, high LH.
And peripheral is more like hormone production happening elsewhere, kind of off-grid with low FSH and LH.
You've got it. That's a great way to think about it.
Okay, that makes sense. Now, the notes mention it's more common in girls, and also that we're seeing more cases in the U.S. and Europe. Any idea why?
Well, the higher prevalence in girls is definitely something we consistently see. The exact why is still being looked into.
Right.
As for the increasing incidence, that's intriguing. It could partly be better detection. We're just better at spotting it now.
Makes sense.
But there's also a lot of research exploring potential environmental factors, maybe lifestyle influences, things possibly affecting our hormone systems. It's definitely an active area of study.
Interesting. The notes also talk about benign variants. That sounds less serious.
Exactly. These are situations where you might see some early pubertal signs, but they don't actually progress into full-blown precocious puberty.
Okay.
So you might see isolated precocious, the LARSH that's just early breast development that doesn't really go any further.
Just the breasts.
Yeah. Or isolated precocious pubarch, which is the early appearance of pubic hair only. And then there's isolated precocious monarch, early vaginal bleeding without any other signs of puberty kicking off.
So it's important to distinguish these non-progressive forms from true precocious puberty.
Absolutely vital.
And just to quickly nail down those terms, the vararch is the start of breast development.
Yep.
And adrenarche is the start of pubic hair growth related to the adrenal glands.
Precisely. These isolated signs, well, they can sometimes cause a lot of worry for parents, obviously.
Of course.
But often they don't actually indicate a serious underlying issue.
Right. Okay, let's dig a bit deeper into what actually causes precocious puberty. We've touched on some of this, but let's really unpack the etiology.
Okay, so the notes really stress the difference between idiopathic and organic causes.
Right.
Idiopathic, meaning we can't pinpoint a specific cause, is actually the most common reason for central precocious puberty.
Okay, the brain-driven type.
Exactly. Then you have the organic causes.
Yeah.
Those are the underlying medical conditions we mentioned. Things like tumors affecting the brain or the hormone-producing glands, hormonal imbalances like congenital adrenal hyperplasia, or specific genetic disorders.
So idiopathic is like the body just starts the process early for no obvious reason we can find yet.
Pretty much. Whereas organic has a more identifiable medical root cause.
And who's more likely to develop this? What are the main risk factors we should be aware of?
The notes flag three key ones. First, Like we said, it's way more common in girls.
Significantly more.
Yeah. Second, ethnicity research shows a higher prevalence in African-American children.
Right.
And third, family history. If there's a pattern of early puberty in the family, that definitely increases the likelihood for a child.
Suggests a genetic component sometimes?
It certainly seems that way in some cases, yes.
Biologically speaking, what's actually happening? What's the pathophysiology here?
Well, the core mechanism, as we sort of discussed, is that premature activation of the hypothalamic-pituitary-gonadal axis, the HPG axis.
Right, the command chain.
Exactly. This early signaling kicks off the release of those key sex hormones, estrogen and testosterone, way too early. And those hormones are what drive the development of the secondary sexual characteristics just at a much younger age than we'd normally expect. It's like the body's puberty orchestra starts playing its symphony way ahead of schedule.
Okay, so the hormones are the main drivers of the physical changes. Now, if a child comes in with these early signs, what else could be going on? What are the important differential diagnoses to keep in mind?
Oh, this is absolutely critical. You have to rule out other possibilities.
Right.
One important thing is just a normal variant of puberty. Some kids naturally start a bit earlier, but they're still technically within the typical range.
Okay, just the early end of normal.
Exactly. Then we have those benign premature, the LARSH or adrenarche cases we mentioned, where it's just one isolated sign.
Right.
Interestingly, hypothyroidism can sometimes mess with puberty timing or presentation, so that needs consideration.
Oh, okay. Didn't know that.
Yeah. And then there are specific conditions like McCune-Albright syndrome and also the possibility of actual hormone-producing tumors, perhaps in the adrenal glands or the gonads themselves.
Wow, so quite a range of things to consider. It's definitely not always straightforward.
Not at all. A careful workup is essential.
And what about the numbers? How common is this condition? What does the epidemiology tell us?
So in the UK, the notes suggest a prevalence of somewhere around 1 in 5,000 to 1 in 10,000 children.
Okay.
And that female-to-male ratio is really striking, about 10 to 1.
10 girls for every boy. Wow.
Yeah, it really predominantly affects girls. It's also worth noting that prevalence can vary a bit between different populations. And as we touched on, factors like obesity might be playing a role in earlier puberty timing, especially in girls.
Right.
Plus, there's definitely a tendency for puberty timing to, run in families.
Okay, so we've got a picture of what it is, who gets it, how often. Now, what are the actual signs and symptoms that would make you, as a clinician or even a parent, suspect precocious puberty?
Well, the clinical presentation varies a bit between girls and boys, though some signs overlap.
Okay.
In girls, the most common first sign is the Lagarche, that early breast development.
Right, the B in your mnemonic earlier.
Exactly. They might also get pubic hair, have a noticeable growth spurt, that's the G, and sometimes show emotional or behavioral changes, the E. So yeah, BPGE works for girls. Breast, pubic hair, growth, emotional changes.
BPGE, got it. And for boys?
For boys, the first sign is usually gonadotrophin enlargement of the testicles, that's the T. They can also get pubic hair, P, have a rapid growth spurt, G, notice body odor, O, and acne. And like girls, might have emotional shifts, E, so maybe TPGOAE for boys.
TPGOAE, testicles, pubic hair, growth, odor, acne, emotional changes.
Okay. And generally for both, you might see that accelerated growth overall and something called advanced bone age.
Meaning their bones look older on X-ray than their actual age.
Precisely, they're maturing faster.
So if a child shows some of these signs, what's the next step? How do doctors figure out what's going on? What's the assessment process?
A really thorough assessment is key. It starts with a detailed history asking about the age the changes started, how quickly they're progressing, any family history of early puberty, and crucially, any neurological symptoms that might point towards a central nervous system cause.
Like headaches or vision changes.
Exactly. Then comes the physical examination, measuring height and weight, assessing the puberty stage using the Tanner scale, measuring testicular volume in boys, doing a neurological exam, and just looking carefully for any specific signs pointing to an underlying cause.
Okay, so history and a good physical exam are the foundation. What about specific tests? What investigations might be needed?
Yeah, there are several important ones. Hormone testing is absolutely key blood tests to measure LH, FSH, estradiol in girls, and testosterone in boys.
Right.
Imaging studies are often needed too, particularly an MRI or sometimes a CT scan of the brain, to get a good look at the hypothalamus and pituitary gland.
Checking for those central causes.
Exactly. And then, depending on what those initial findings suggest, there's a whole range of additional tests we might use.
Okay, like what? What else might be needed?
Well, we might check early morning testosterone in boys,
Mm.
as levels tend to rise early in puberty. We look at random LH and FSH.
Hmm.
If those gonadotrophins are low, but sex steroids are high, that points towards that peripheral type.
Makes sense.
Thyroid function tests are important to rule out hypothyroidism. If congenital adrenal hyperplasia is suspected, we check adrenal steroid precursors.
Mm.
If there's any concern about rare HCG-secreting tumors, we'd test for human chorionic gonadotropin. We might also look at urinary 17-ketosteroids. They give an idea about adrenal androgens.
Okay.
Then there's diagnostic imaging like pelvic, testicular, or adrenal ultrasounds. Hand and wrist x-rays are standard to check that bone age we mentioned.
Right, the bone age X-ray.
Yeah, and maybe a pelvic MRI in girls. And finally, there are specific stimulation tests like the GnRH stimulation test or leuprolide acetate stimulation testing. These really help see how the pituitary gland responds, confirming if it's truly central activation.
Wow, that is a comprehensive toolkit, really trying to get to the bottom of what's driving it.
It has to be. The treatment depends heavily on the cause.
Right, so once a diagnosis is made, what are the main management approaches, say, in the UK?
Okay, so for central precocious puberty, the primary treatment in the UK uses gonadotropin-releasing hormone analogs, or GnRH analogs.
GnRH analogs, how do they work?
They essentially work by downregulating the pituitary receptors, effectively putting the brakes on the body's own production of LH and FSH.
Mm-hmm.
This halts the progression of puberty.
Okay.
They're usually given as monthly injections. Now, obviously, if there is an underlying organic cause found, like a tumor,
You treat that first.
absolutely. Treating the root cause is the priority then. And really importantly, providing psychological support is crucial for the child and for the family. Dealing with puberty years ahead of your peers can be really tough, emotionally and socially.
I can only imagine. Are there other treatments for specific causes?
Yes, the notes mention surgery might be needed for certain tumors. For congenital adrenal hyperplasia, glucocorticoids are used to manage the hormone imbalance. And for specific rare conditions like McCune-Albright syndrome or something called testotoxicosis, medications like aromatase inhibitors might be used.
Aromatase inhibitors.
Yeah. It really just highlights that the treatment plan has to be tailored very specifically to the individual child and the underlying cause.
Okay, so a very personalized approach. What about the long-term picture? What's the prognosis generally like?
It really depends heavily on the cause. For idiopathic central precocious puberty, the main concern without treatment is potentially ending up with short stature as an adult because growth finishes early.
Right, the bones mature too fast.
Exactly. But with proper management using those GnRH analogs, we can often slow things down and significantly improve their final height potential.
That's good news.
Yeah. And interestingly, the notes mention that for girls who develop central precocious puberty between, say, 6 and 8 years old, even if they aren't treated, many may still reach a normal adult height.
Oh, really? That's interesting.
It is. For precocious puberty caused by other things, an organic cause, the prognosis varies a lot, depending on what that cause is. But generally, catching it early and getting the right treatment leads to better outcomes.
So early identification and intervention seem really key across the board.
Definitely.
What are some of the potential downsides or complications if precocious puberty isn't managed effectively?
Well, the notes highlight several important ones. There can be significant emotional and psychological challenges. Imagine being physically developed, but emotionally still a young child, dealing with peers who aren't going through the same thing. It can affect self-esteem, social interactions.
Yeah, that sounds incredibly difficult.
It can be. Then there's the short stature issue in adulthood due to that premature growth plate fusion. Behavioral issues can sometimes arise, things like aggression, anxiety, maybe even depression. And depending on the cause and treatment, there might be potential concerns about future fertility down the line, although that's quite variable.
Okay. These are all really serious potential consequences. Now, thinking about remembering all this, do we have any handy memory tips? Or maybe an example question to make it more concrete?
Absolutely. For remembering the two main types, central and peripheral, you could think central, brain start. The issue starts in the brain's control system.
Brain start. Okay.
And peripheral, power elsewhere. The hormones are being made somewhere else, outside that central control.
Peripheral power elsewhere. Nice.
And maybe for some central causes, think TTT, trauma, tumors, and things they're born with. Congenital issues.
Trauma, tumors, things they're born with. Good one. What about an example question, like something you might see in an exam?
Okay, how about this? An 8-year-old girl presents with 2 years of progressive breast development and the recent onset of pubic hair. Her height is noted to be above the 95th percentile for her age. Initial blood tests show elevated levels of both LH and FSH. What is the most likely diagnosis? And the options are A, premature at the large, B, gonadotrophin-independent precocious puberty, C, normal variant of puberty, D, gonadotrophin-dependent precocious puberty.
Okay. So progressive signs, accelerated growth, and crucially elevated LH and FSH, that sounds like the brain is driving it.
Exactly.
So that points strongly towards D, gonadotrophin-dependent or central precocious puberty.
Spot on. That's the reasoning. The high LH and FSH are the key differentiators there from peripheral causes or benign variants. And a super quick way to remember the age cutoffs. 8 is the gate. For girls before that, investigate.
8 is the gate.
And for boys, 9 is the sign. Puberty, starting before 9 needs looking into.
9 is the sign. Perfect. Those are really helpful. Okay, so to wrap things up, what are the absolute key takeaways from our deep dive today?
Well, I think number 1 is understanding the definition. Early sexual development, before 8 in girls, 9 in boys.
Yep.
Number 2 is grasping that fundamental difference between central brain-driven, high LH-FSH, and peripheral hormone-driven elsewhere, low LH-FSH. That's crucial.
Central versus peripheral, got it.
Then, knowing the range of potential causes, both idiopathic and organic, and the key risk factors like gender and family history. Recognizing the clinical signs, like the Larsh in girls and Godard in boys, plus accelerated growth. Remembering the importance of differential diagnosis and the key investigations like hormone levels, bone age x-rays, and brain imaging. And finally, understanding the main management, primarily GnRH analogs for central PP, treating the underlying cause if found, the importance of psychological support, and having an idea about prognosis and potential complications like short stature.
That's a great summary. It's definitely a complex area, but hopefully breaking it down like this has provided a clear and useful framework for understanding it.
Hope so.
And for anyone listening who wants more MSRA revision resources, definitely check out passthemsra.com and also freemsra.com.
Great resources.
And on that note, here's a final thought for you to consider. Given how sensitive early puberty is, what do you think are the most critical ways we as a society and as healthcare professionals can better support children and their families navigating this really challenging experience? Something to think about.